Great. So welcome back, everybody. And I'm assuming there's a bunch of people online. I'm going to keep my comments really short. And this session is really focusing on much more on data and what we know about COVID in India. And just before we began this session, we were having a little bit of a side chat about the complexity of data in India around COVID. And complexity is my nice way of saying it's a bit of a mess. It's been a challenge. The bad news is that the data in India has been a challenge. The truth is, this is not a uniquely Indian problem. And we could spend quite a bit of time talking about the challenges of data in a country like the United States, where still fundamental questions around what is happening with COVID are pieced together by looking at 8 different data sources and trying to sort out how it's all going. But for India, this is particularly important, and I would say arguably over the whole pandemic, but certainly in the most recent massive wave that India experienced. I think many of us felt that we were really missing a lot of infections and hospitalizations and deaths during that time. There is no better trio to walk us through the state of play. And I'm going to very quickly introduce all 3 of them, and then I'm going to have Brahmar come up first, and then Arvind, and then Patrick Heller. So first, we're going to start with Brahmar Mukherjee. And I should have asked you how to pronounce the name of your professorship, Kalbfleisch? Kalbfleisch. She's a Kalbfleisch collegiate professor at the University of Michigan, chair of the Department of Biostatistics. And really no one I can think of who's been doing a better job and more insightful work tracking the pandemic in India. And she may be tired of it, but COVID is not tired yet. It's still going, and none of us are tired of you doing it. So you've really been the leading person on this. And so we'll start with Professor Mukherjee. Then we'll go to Arvind Subramaniam, who is a senior fellow here at Brown, previously a professor at Ashoka University, served as the chief economic advisor to the government of India from 2014 to 18, I believe, and has a really interesting paper about what's been happening with deaths in COVID. And I'm confident he'll cover that and maybe other topics as well. And then last but certainly not least is Professor Patrick Heller, also a professor here at Brown, professor of sociology and international studies, director of the graduate program in development. And he's going to finish us off in this panel. And then I will come back up after each person has had a chance to do their presentation, and I will lead the Q&A. So I'm going to start it over with Professor Mukherjee first.
Thank you so much, Professor Jha. And it's an absolute honor to be able to do this panel and also to be able to do this in person. My first panel in 2 years. So I'm very, very excited. So I want to talk about the work that we started in March of 2020. And no one predicted that I'll still be talking and modeling this pandemic. But then I think so that's where the failure of predictions or the prediction talk. And so, you know, I always dreamed, and I was when I was getting my education in Indian Statistical Institute, I dreamed of like Bengalis always dream of revolution. So I dreamt of data revolution. And I had an army of data warriors actually this time to contribute. And we started this work when all of us were sort of feeling lost the first day of the stay-at-home orders at Michigan. Many of us have family and loved ones in India. We are not sure when are we going to see them back again, what's going to happen to that country. And so it's really, we wanted to repurpose our anxiety into something meaningful. And that led to, we are not an infectious disease modeling team, but that led to creation of this app, which has real-time projections and also public health metrics and assessing interventions in India. So if you logged into the app on the landing page, you'll see on May, the things were really, really bad. And there were a large number of deaths and cases happening. And it gives a snapshot of today, yesterday, 1 week ago. And things fortunately are much better now as we are walking into September. So always the trepidation is, when is the third wave coming? But in the basis of like all the conversations that have happened since this morning, I want to say that there is much more to COVID than data and epidemiology. And we are talking about numbers, but these are people's lives, our whole society, the global scenario has been really changed and transformed, and lots of new images have transpired out of our realization of what is quintessentially important to our society. And there are many things that India and all of us need to focus on in terms of healthcare access, equity, long COVID, economy, education, the list goes on. But I'm going to primarily focus on data, because that's where that's the lens through which I see the problem. So I want to make 3 points, because I was given 15 minutes of remarks, and each of them I'll try to spend 5 minutes. The first one I want to say is the current state of the pandemic in India. And I want to talk the second point, I think it is going to be reiterated by the next two speakers as well, about data paucity and data opacity. And then I want to talk about the role of predictions and what role early interventions could have played, because as a statistician on a computer, you can play God and create all the counterfactuals that what could have been. So I'm going to show you some what could have been scenarios and how many lives we could have saved. So if you look at India and United States right now, as we can see that India in the first wave really flattened the curve. It's a true example of flattening the curve. And then the second wave was really sharp, and the rise was also sharp in the last April to June. And even with 56% population vaccinated, we are witnessing a wave in the United States right now. So we can see, if we look at the curves, that is it done yet? When is the third wave going to hit India? I keep being asked this question. I feel like I'm becoming a data astrologer, but I'm going to tell you about that too. So India saw a very strong national lockdown, and we have heard about that from Barkhadat in the morning, the two sides of the lockdown. And this is the effective arc trajectory in India over the last 2 years. And for the sake of defining a second wave, I'm going to define it starting on Valentine's Day 2021, when the arc trajectory first crossed unity. But we are already talking about the second wave. By the middle of February, it was really clear that many people were talking about it. In some states, it was quite evident in January of 2021 as well. So right now, 33.1 million reported cases, 440 to 450, depending on how you count, deaths, 2% test positivity rate. Every day, 30 to 40,000 daily cases happening, 300 to 400 daily deaths, case fatality rate standing at 1.3%. If you compare in terms of wave 1 and wave 2, one thing that you notice is that the wave 2 has been much more acute. So if I just divide it in terms of the time span, wave 1 was much longer, but we do see that the intensity in terms of the height of the peak, in terms of how the curve grew, was much, much sharper in wave 2. Still, the fatality rate are remarkably similar if you consider case fatality rate. Vaccination, I think India, after the first initial struggles, have done relatively well in recent, like in the last few weeks, actually have been really good. And but it's a large country. So in terms of the total absolute number of vaccinations, 700 million doses have been given. And we have to applaud the country for that. And then percentage of population with 2 doses, 12%, with at least 1 dose, 40%. So last few days, about 7 to 8 million of daily doses, which is exciting and which is really a good positive change. So, but India is not just one nation. India is multiple nations within the nation. And I know that this is very tiny fonts and you cannot see it because we are very used to sharing our screens on Zoom where you can see everything. So we built a daily tracker, but I anticipated that. So each row in this table where we actually report daily metrics and public health metrics, point in time and cumulative, we show that what is happening in each of the states. And the last few weeks, you have heard probably a lot about Kerala. Kerala is contributing more than 60 to 70% of India's cases. So when you analyze India now, you have to really analyze Kerala and India without Kerala, because the trends are quite different. So you can see that in the blue curve is India without Kerala, and this is India with Kerala. And Kerala is contributing a large number of cases, but not proportionate number of deaths. That's something that we have to keep in mind. So we can talk about the Kerala conundrum, but let me first tell you that when the third wave is going to hit. So this is the IHME model, which also, so let us first look at estimated infections. So this is what was observed in April and May, India's towering second wave. And as you go in time, these are the three different scenarios of intervention, and you do not see a towering peak. You do not see a third wave. You see a little bit of bump in November, December, if you go to the worst case of masking and human behavior. One thing I want to point out that models can also predict estimated deaths. And so this is the IHME model prediction. As you can see that the red curve is what was reported, and this is what was actually predicted or estimated. And so we also have a model-based estimate of this excess deaths I'm going to come to. And again, in terms of deaths also, we see that there is a little bit of bump. So Indian Express last 1 month has been all journalists reaching out to when is the third wave happening? And there was lots of articles even saying the third wave has started on July 1 or July 4th. I wanted to ask them that what is the hour and the time? It almost seems like a lunar wave. So please tell me that. But it is not based on data. It was based on, I don't want to go out and public and saying that we do not see a third wave because it's all in our hand. And also human behavior might change if you go out and say that there is no threat of third wave. So, but this is, I have to be true to the data and the models, and we are not seeing anything in the next 2 to 4 weeks. So what do we ideally need? As a modeler, I feel incredibly challenged at this time when so many things have changed from the early days of the model, because you need a model for virus transmission, which we have in our, that's our primary tool. And then we need a model for human behavior. We need a model how vaccination projection is going to go. We need a model for virus mutation process, the variant landscape, what is out there. We need data on reinfection, breakthrough infection. We need a model for policy intervention. What is the effect of each of the policy interventions in India? So a stochastic system in constant turmoil and always many steps behind. So we have to, as a modeler, we have to be able to recognize with humility what is the limitation of all we are saying. And the race is going to be between the vaccine and the variant. So this is the variant landscape in India over time. And as you can see quickly, the Delta has become the dominant lineage. And so what is in here, that's something that we have to catch early. And similarly, in terms of vaccination, this is some of the data that we use in our models that by the end of the year, actually, this is December 1, projections are that 31% of Indian population will be fully vaccinated and 52% partially vaccinated. So these are some of the informations which are going back into our models now because the situation is just not simple. We have a multi-strain compartmental models. We have all of these other inputs that we need. So it is a lot more uncertain. So I want to talk about the data paucity and data opacity, which has made this work remarkably challenging. But I do believe that even in the worst possible data, you have to do the best possible statistics. So you have to really, this is your job as data scientists. So good models need good data, and we don't have them. So, it's a truth. We all recognize that capturing all COVID infections and deaths is nearly impossible for any country. And that's because of the asymptomatic infections, lack of access to testing, misclassification of deaths due to other causes. But there is also a desire to maintain public image. So we heard that some countries in the region have done better, but is that really the true case count and the death count? So then why are we so concerned about India's reporting? Just because we come from India? No, that's not the reason. I just want to show you that there are 3 kinds of fatality rate matrix widely quoted in the literature. One is the case fatality rate, which you always see, which is just based on reported number of deaths and reported cases. Then there is the infection fatality rate. This second measure is what is most dangerous, where you correct the denominator of this measure, saying that the total number of infections, but you say that, okay, I am correcting for the uncertainty in the denominator, but the numerator I do know. That does not make sense to any data scientist, right? If you are missing deaths, you are missing infections, then adjust for them in both the numerator and the denominator. So you need to look at that measure. So one amazing thing about India is that India has serially done reported serosurveys, nationally representative serosurveys. So let us look at the trend of serosurveys and what percentage of Indian population was affected in the presence of antibodies. And this is prior to vaccination campaign, how that has grown over time. According to the last serosurvey, 67% of Indian population has antibody. So if that will give you a 765 or nearly 800 million infections, and you're reporting only 30 million of them, so your underreporting factor is somewhere between 1 out of 25, 1 out of 30. We have always estimated it to be 1 out of 20 for 20 or 30. So now in a recent paper, we did a meta-analysis of all of these. If you just based on that IFR, which I think is a completely erroneous metric, where you are just correcting the denominator and not the numerator, your IFR is going to be 0.1%. And that's not correct. And you're going to see that's being quoted, and that's incorrect if someone is saying that. So how to quantify death underreporting? Professor Subramaniam is going to give you a much more illuminating exposition to that and the data resources. You heard from this morning that Barkha's estimate was 1 out of 5, and that was based on actually a group of volunteers in Kerala just tabulated obituaries that were published. And then there are reports from crematoria, burial grounds, and also journalists have done tremendous work in this space. So we need to be able to do a formal calculation. So there is a paper by Steve Wolf in JAMA, which actually says that US experienced by the end of the year 22% excess deaths, but 72% of that was attributed to COVID. So all of the excess deaths cannot be attributed to COVID either. So that's something that we have to think about, the delay in care. So lack of comprehensive data makes these calculations very difficult for India. There's a recent study of 77 countries doing excess death calculation. India was left out because there is no comprehensive data. So we went and deep dived into the literature in medRxiv and did a PRISMA guideline meta-analysis and evidence synthesis. And the excess death estimates in India till the end of June vary from 1.8 to 4.9 million deaths, and where the total number, the actual reported number, is 412,000. So even the lowest estimate, it is 4 to 5 times more the observed one. So the death reporting underreporting factor is from 4 to 12. So if you actually then analyze this range of estimates and do a meta-analysis of that, you see that the infection fatality rate is somewhere between 0.4 to 0.5%, which is much more sensible. And you have to think about age composition, and it will not look very low in the light of the rest of the world if you actually consider age pyramid. So that's the point that I wanted to make, that you can change the fatality rate metrics depending on what you do. And I do believe that somewhere here is the correct answer. So my data wish list, this is like, when I'm like, but like I just write down, this is what I want. This is what will make my model very nice, but doesn't happen. It's not going to happen, but still I'm going to dream. I'm going to dream because I'm a data dreamer and I'm not the only one. And so why is it so hard to find age and sex stratified data on cases, tests, deaths, and vaccination in India? There is no reason you cannot find it. And so if you cannot find it, then it's very difficult to talk about mortality without age, right? We know that. And then the last point, there are many other things on my wish list, but the first and the last one I have actually learned from my daughter is the most important one, that the last one is, if you don't link the genomic sequencing database, the testing and the vaccination, you'll never know the rate of reinfection, cluster infection, breakthrough infection, and this variant versus vaccine landscape. And we need to know hospitalization and fatality rates related to each. So this is my wish list, but the first and the second are like really uncompromising, that we do need it. The third point and the last point, and I have been criticized a lot in the media every day, where actually transmits this interview that I gave to Karan Thapar about this recent paper, where we quantified this what if interventions that were rolled out in Delhi and Maharashtra in April were done in March, a month in advance. So the landscape of interventions in India, wave 1 versus wave 2 is very different. Wave 1 saw a strict national lockdown, whereas wave 2, we saw political rallies, we saw religious gatherings, we saw big weddings happening. There was absolutely no intervention. So, but we know that these work. So even in Delhi and Maharashtra, there was like 28,000 cases per day, came down within less than a month to 1,500 cases per day. So we do know that public health interventions work. And we can actually probably quantify the effect of different kind of public health intervention. I do not want to do a post-mortem analysis or retrospective analysis to criticize people. I want to learn from this and want to say that what type of interventions is changing my transmission parameter, the effective reproduction number, by which amount. I want to quantify that effect size so that in the future, I have a dial up, dial down menu. When do we start an intervention? When do we lift an intervention? And what would be the consequences? So what we did in a recent paper is actually estimated this intervention effect from what happened in Maharashtra during the pre-lockdown period, the lockdown period and unlock period in 2021, and said, let us play God and just shift those interventions, the same interventions by a month, by 2 months, and see how many infections and how many lives we could have saved. So by acting early, and if we did not even need a lockdown, if we had acted in January or February with intense public health intervention, we could have prevented nearly 18 million reported cases and 210 to 220,000 deaths. That's 95% of reported deaths. And if you apply it to the unreported deaths, you can see the magnitude of the number of people you could have saved with just acting early. Timing matters. So moving forward, of course, we know that, like, we have to vaccinate. We have to, but the point is that strong adherence to modest interventions can really help us avoid these lockdowns. And we have to look at humane lockdowns. There was a recent paper on human shelter at home as opposed to these harsh lockdowns. And then we know, we have to, in the history of infectious diseases, how many viruses we have been able to eradicate completely. So even in a vaccinated population, we have to, these public health interventions are here to stay. There will be outbreaks. We have to be prepared. And something which has not been very well emphasized, testing as an important component of public health intervention, with these at-home tests that are available to really, in the post-vaccinated world, to keep checking as we safely open our workplaces, our schools. This is incredibly important. So we have learned a lot. Those of you who are in the room, who are listening virtually, we have learned how to be scientists and how to be leaders. I chair a department. In the future days, our struggle is not over. We are all tired, but we must lead with science, and we must lead with humanity. So everyone has their favorite story about this pandemic. So I went back just one day before the US elections. You can imagine why, to India in wave 1, because I was really missing my parents. My parents are octogenarians, and they were giving up hope that they will ever be able to see me again. So here I am, dressed like an astronaut in a hazmat suit. I cannot believe, this is me, truly, honestly, in front of Chicago airport. And I spent 2 months in India with my parents. That's a lovely time I'll never forget. So all of us have learned a lot of life lessons as well. So what choice do we have moving forward? So I'll just end with a poem, because sometimes, where science needs poetry, that Rilke's poem, let everything happen to you, the beauty and the terror, because that's what life is all about. Just keep going, because no feeling is final. We are feeling confident with the vaccines. That feeling has changed. We have trepidations now. This is a picture of a man who is walking, and this is in my home state, West Bengal, during a cyclone Amphan. As a human race, amidst cyclone, amidst a pandemic, we keep walking. What choice do we have? Thank you very much for your attention.
By the way, for people who are online, please put in your questions into the Q&A, and we're going to grab them during the Q&A session that follows.
Good afternoon, everyone. First of all, thanks to Ashish and to Ashu in virtual space for inviting me to this wonderful conference. I'm really thrilled to be part of this panel, and I just heard an amazing presentation by Brahmer, and I'm going to be followed by Patrick. So I'm really privileged to be part of this panel. I'm kind of a boring economist, and it's going to be a fairly boring presentation that I'm going to make. So this is a paper that we wrote, which came out about a month ago, updated some of the numbers. 3 estimates of India's all-cause mortality during the pandemic, and it's joined with my, Abhishek Anand, who's now at the World Bank, Justin Sandifer, who's at the Center for Global Development, and me. So without further ado, let me, I'm kind of going to be really building on what Brahma has presented on one aspect of her presentation. So the motivation, obviously as an economist, I've been following the numbers of the pandemic right from the start. And throughout, it always kind of bothered me that, just as Brahma was talking about, being careful about the numerator and denominator, it was always, it's always a problem working on India that people focus on the absolutes, and then either that leads to, complacency, or it leads to kind of panic, and I think certainly for me, the motivation for this exercise was, you look at the official count as of end June, if you looked at it, 400,000, and as Brahma said, about 450 now, perhaps. But the number that I was focusing on was what is the kind of excess deaths per capita or per million throughout. This is a chart from the Financial Times, which was doing this early on, as of May 5th, just before kind of the vaccinations began. That's kind of the time frame that we focused on. And what you find is that, these are the excess deaths per million. You can see that Peru's on top, the Latin American countries, then the European countries, and then, some of the others down below. And if you were to believe the official numbers in India, both on the infections and on the cases, India would be, as the arrow shows, has done as good a job as Israel. And to be honest, I think it was this sense that, focusing on this actual cases, I think, to be fair, there was a very strong sense in India as of January, February, that, India was different, India had cracked it. And I don't mean to kind of point fingers at all. All of us to some extent were, to be honest, we succumbed to this. And I think in March of 2021 or February, Siddharth Mukherjee had a piece in the New Yorker, very much along this thing of, how did India do it? And so, and I think part of the problem was, focusing on the official numbers. And, it just seemed to me that if you were following the seroprevalence studies in India, and if you applied some reasonable sense of, the IFR2 that Brahma spoke about, just could not be right, that India could not have done as well as Israel, in the chart, because, and even if you look at as of end June, India's infection rate is like 70% almost. And, and to say that we have 400,000 deaths just did not pass the smell test. So the question is, could we do better? And for a long time, and as Brahma pointed out, even today, the data set, the excess data set that Ariel has put out, it does not have India. And certainly for a long time, there were no data-based estimates for all-cause mortality in India. And there were model-based estimates, including by Brahma, IMHE economists, but there were no data-based estimates. And of course, the problem in India is that the official death estimates, which is, in India, there are 2 ways of doing it. The way it's done is that the states report deaths based on the civil registration system. Then, the central government does the SRS, the sample registration survey, but that's been lagging by 2 to 3 years. And so, we were all in the dark as to what was really happening. And, it's a real tribute to Indian civil society, Indian journalists, that in the first wave, there was excess, people thought we'd cracked it. So there was no real urgency to get to kind of the true number. As you know, there's a famous Bob Dylan line about how many deaths will it take till we know that too many people have died. In a sense, it was exactly the opposite. It's only because of a sense that too many people had died did we go back and try and get a sense of, how many actually died. And so that happened in the second wave because of the surge of deaths. And, the number of journalists, civil society people, and they're all listed here, Rukmini, Srinivasan, Dhanya, Tejesh, and then of course the newspapers, the Gujarati newspapers, Gujarat Samachar, Sandesh, Suresh Bhaskar, then Dainik Bhaskar, The Hindu, NDTV. In some senses, these were the real heroes and heroines of getting a crack at what was really happening in India during COVID. And then, of course, so that happened. All these journalists basically tapped into one source of data, which I'm going to talk about. And then, fortuitously, Anup Malani at Chicago and Sabrish Ramachandran, and we also almost simultaneously, and I put this in quote, we discovered a potential data source that it was the only consistent longitudinal survey of since 2015 that was tracking deaths as well. Now, this survey, I'm going to talk about that a little bit later, but so we kind of discovered the source. So we said, let's take a crack at it. First, of course, what we're calculating is all-cause excess mortality, not COVID mortality, for reasons that are very clear. And we wanted to make clear up front that all the data sources, all the methodologies are problematic. There is no one good source or one right methodology. So, I mean, it's a question that even Brahma said, should we wait or give up? And, our sense was, no, we shouldn't give up because, follow the scientific method, use all sources available, be completely transparent on assumptions and methodology, be aware of all the biases and limitations, be careful about conclusions, and of course, let 1,000 flowers bloom. I think now it's fair to say that there are now many, many more estimates or data-based estimates of all-cause mortality in India. And I'm going to say, at the end, say how all of these are probably converging to some, broadly similar numbers of the sort that kind of Brahma put up in her presentation. So we use three sources: the civil registration system, which is essentially state governments record deaths in India, and that's the civil registration system. Second source, we said, as Brahma quite rightly pointed out, sero prevalence in India survey have been very good, very consistent, very well done. It's a pity that the data was not all released and made available, but I think at least even the aggregates, very consistent, very good. So we said, let's use the sero prevalence data from India. And since we cannot, by definition, calculate IFRs from India because either the numerator or denominator or both were mismeasured, let's try and use some international numbers. And the third data source was this longitudinal survey panel data that the Center for Monitoring of the Indian Economy, it produces every 4 months. And other databases, there's a lot of good work. Anup's work with Sabarish, Murad Banerjee and Ashish Gupta have done some very good work. Prabhat Jha, Chinmay Tumbe, they also have a paper, and I'll tell you what their numbers are. And of course, they're model-based estimates. IMHE, Brahma, and others have done that, but I'm focusing here on data-based estimates. So this is our bottom line. 3 rows, you see the 3 data sources. I'm going to describe them in greater detail. We slice wave 1 and wave 2 slightly, just about 45 days different from what Brahma did. It's probably, maybe we should have started, March 1, we started April 1. I don't think it makes, maybe makes a little bit of difference, but not a whole lot. So our estimate is that the 2 bottom lines from our estimates, our studies is that, total deaths somewhere between 3.5 and 5 million. And so that's kind of one, and that's about, 8 to 9 times the official count. And the second thing I want to emphasize here is that the first wave was probably more serious than any of us believed at the time. So I think these are the 2 big takeaways. And what's heartening is that even the 3 ones, so the only, I think we really added at the time we did was to actually do it in 3 different ways and kind of triangulate towards something that seemed to show some convergent estimates of these numbers. So somewhere between 3 and 5 would be my sense of where the numbers are as of end June, and probably about 1 to 1, maybe about 1.5 to 2 in the first wave, and 2 to 2.5 in the second wave. Now, each has problems. The CRS undercounts deaths, and we know from other data sources, it undercounts deaths. B, the undercounting change varies across geographies. Kerala, that Patrick is going to talk about, does a much better job. Bihar does a much worse job. And it also varies over time. So in fact, the degree of undercounting in the CRS has been declining over time. And of course, the other important caveat I want to say about these estimates is that even the CRS as of today does not have data for all the states. And certainly for a number of states, the data stops in May 2021. So June, we're not yet picked up, and July, so these numbers could go up. And then of course, you have to make all these assumptions about when you estimate the COVID period. Is the undercounting the same? Has it gone down? Has it gone up? You have to make all these assumptions about what undercounting. And so we say what our assumptions are, and that's how the numbers we come out with. What is interesting is, as Brahma said, it varies widely across states. Now there's data for 13 states in the CRS. And I would say that the Uttar Pradesh data, certainly for wave 2, is not plausible at all. In any case, it's only available for April. It's not even available for May and June. It's not plausible at all. But what you find is that, it gives you these numbers, but it's the last column that I want you to focus on, because again, I think the right metric to compare is what were the excess deaths per capita, even across the states. And you find some very surprising results. Chhattisgarh 5.8, Andhra Pradesh 4.6. Now, these are excess deaths per capita, close to what we've seen in Latin America, in Peru and Mexico and places. Madhya Pradesh very high. So broadly, you get excess deaths per capita, cumulative, somewhere between 2 and 3, which I'm going to show you at the end, is that India places India in a much more kind of realistic pecking order in terms of what actually happened by way of outcomes. Second, I think this is, we use Indian seroprevalence plus international IFR, and the international IFR we picked up based on the CDC recommended study. But then, I was careful also in going through all the other studies that have done meta-analyses on this. And essentially what you find is that, so what we did was we take the disaggregated age-specific IFRs based on the meta-analyses and apply it to Indian demography, because demography makes a huge difference. And then we, so at least we control for Indian demography, and that's what we use. It's a very simple procedure. And, and as you know, India's IFRs are very spotty. And what we come up with is 1.5 for the first wave, 2.4, because remember, if we are right that the first wave begins sometime around, say, March, we know that around March, probably seroprevalence was close to 25%, because at end June, we know it was about 22%. So essentially, the second wave, we've got between 25 and 70%, so about 40 to 45% of sero cases happen in the second wave, first 20-25% in the first wave. So that gives you kind of proportionately, although I'm going to tell you it's not quite right for reasons that I want to mention in a second, but we get an IFR based on this of 0.54, which is just outside, and very comforting to know that's just outside the meta-analysis that Brahma just presented. And I think that's much more realistic for India. Now, see, I think there was, if you remember the early days of the pandemic, there's some very respectable opinions saying, BCG in India, temperature, therefore, we had more immunity in the population, therefore India's IFR was going to be much lower. But then we also know that Indian health capacity is much worse. So if you actually look at some of the papers that came out, in the early stages of the pandemic, almost most of them that I've seen said IFRs, age-specific IFRs would probably be greater in developing countries because the health capacity thing would dominate the age-specific thing. And so, so it's 0.54. Now, I think that I'm happy with, or I can't feel too uncomfortable with the 0.54, because it's almost certainly the case that the IFR in the second wave was much greater than in the first wave, because the surge was so sudden, health capacity was so strained, shortages were so acute that it had to be the case. For example, there's a study on New York which shows that between March and May of 2020, in New York, with all its, first world thing, IFR went up by almost 1% from 0.25 to close to 1.25% because, so if this can happen in New York, I mean, surely there's no reason why it cannot happen in a country like India. So I think you combine these two, you get the number that we have. The CPH's Consumer Pyramid Household Survey, it's a very interesting survey. It's very controversial in India because people think, it's not representative, et cetera. But to be fair, it is the only data source that is tracking. The aim of this is not to track mortality at all. It's actually tracking expenditure, labor market outcomes, and so on. But just as a kind of, getting their sample right, they track mortality. So 177,000 households surveyed once every 4 months. So over the course of these 4 months, quarter of these households are surveyed every month. The latest survey is actually, that should be updated. There's now one out, which we're going to, hopefully we'll update the data, which goes through to August. So this will be the first survey that will give numbers for the full second wave, June, July, August, which we don't have so far. Even in the CRS, we don't have any data on June. So all these questions about representativeness. So this is what the CPH's mortality data is showing in terms of the annualized death rate. And remember, the number to keep in mind is India's baseline death rate is between 6.7 and 7. About 10 million people die in India every year. So you see on the y-axis, picture 7 as the baseline, and you see what's happening in the data. So the issue with the data was, is it reliable enough in the pre-period? Does it get validated by other sources of data that we can then use it in the post-COVID period to get some numbers? It turns out that, it doesn't really get validated by other data in the pre-period. For example, if you do this across states, across time, there are discrepancies. They don't seem to be systematic discrepancies. But the most worrying thing, you see that big circle, the data seem to show a big spike in 2019. It's almost as if there was a COVID wave in 2019, well before the pandemic. And that's why you see the orange and the red line, which is the COVID period. When you want to calculate all-cause mortality, what is the baseline that you should use? And if the pre-period is not, you can't validate the post-period, lots of question marks. So we do this, very, very cautious estimate based on a baseline which is kind of bumped up. And what you find is that you get a number closer to 4.9 million. Now, Anup and Sabarish have an NBER paper which has just come out for exactly the same period. Their number is 4.5 million. But unlike ours, we have much more in the first wave than they have, and they have more in the second wave. So the timing varies between us, but the number is very similar. Theirs is 4.9. And by the way, the paper by Prabhat Jha and others, they also have a range between 2.5 and 4, which they've come out with. So conclusions, yes, it's now possible to take a stab at these excess death estimates. All of them are asterisked. Be careful about how you use them. But if there's any comfort in all this, it's that all of them seem to converge to some pretty high number, much higher than what we believed. And I think I strongly feel that had we focused on the right numbers in the first wave, maybe we would have been a little less complacent. So are these numbers high or low? Because remember, in India, all of us got attacked for saying the numbers are much greater and so on. But if you think about it, essentially, the bottom is where India official, and with this new number, India is kind of closer to the top. And I would say, you get excess death per capita of something like 2.5 to 3, which seems to be a much more plausible. Last point, of course, is that The Economist has just put out their global excess death mortality estimates. And India, if these numbers are even remotely true, India just shifts the global needle by this excess mortality. So as in all things, the Indian problem is just an Indian problem. It's kind of a global problem as well. And I think one big lesson from this, of course, is that we need much better data systems in India. I mean, and I think to be fair to the government, and I mean, this is not a case of fudging or whatever. It's a case where basic capacity, health capacity, data capacity is weak. There may be at the margin some incentives to be not be completely forthcoming, not have full disclosure, but overall it's a case for strengthening health capacity, especially on the data side. So thank you all very much, and look forward to it.
Yeah, Grace, I'm going to need your help. I know. Here, I'm going to let you do this before I make a mess of it. And I just also want to begin by thanking Ashu and Ashish and Grace and Stephanie for organizing this first in-person event and doing it the first week of classes, which is wonderful timing. Exhausting, and I want to thank Brahma and Arvind for those extraordinary presentations, and also take the opportunity to, along with the two of you and Ashish and Ashu and Barka, for having been so extraordinary in the public sphere. I mean, one of the silver linings in this crisis is that academic work has been extremely relevant and part of the public conversation. It's thanks to people like you that it has had such an impact. So I'm going to do something very different. I'm going to talk very briefly about the data, but fly by it because we've already heard all the really good stuff on the data, and talk more about the politics of all this. And this is work that I've been doing with Ani Adhikari, who's just back from 1.5 years in Delhi and is a PhD student here in sociology. Kalai Arasan A, who's from the Madras Institute of Development Studies and is here with us at Brown for the year as a Fulbright Fellow, and Yeva Sumbieta, who may be online, I'm not sure, but she's in Chennai. And the four of us, we've been tracking different states in India for the past 1.5 years, tracking the data, but tracking the politics, and in particular the policy responses, both to the COVID crisis, but also the welfare interventions. And I'm going to bracket the welfare interventions today because I just don't have time to cover that. But what I want to do is essentially try to connect the outcomes to what we in the comparative literature call political regimes. We all know there's tremendous variation in India, more variation than within Europe, more variation than across nation states in Latin America. But what's truly extraordinary about the Indian federal story is not just that the states are different, the political systems are completely different. There's no other federal democracy in the world, Brazil, Germany. The US, it's simple, it's binary, it's red, it's blue, very simple. India, there's 28 different states, there's 28 different political configurations. And so maybe there's a relationship between political regimes and how subnational states have actually responded to the crisis. So I'll fly by this data because you've just heard something way more sophisticated. But the larger point here isn't so much the absolute numbers. We know that they're deeply problematic, et cetera, but the really extraordinary variation across states, right? So whether it's the vaccine rates, yes, India's doing much better, but obviously Kerala is doing a lot better than Bihar. Whether it's the actual reported infections, Kerala is off the charts, as we've heard, and yet the seroprevalency in Kerala is the lowest in India. So clearly they're doing way more testing, they're getting to more people. And then the same, whatever multiplier you're taking, the figures that Arvind just gave us, or these are calculations that Kalai did, or this is what was reported by the ICMR, Bihar is undercounting by a factor of 134, right? I mean, it's just all over the place. But there is a bit of a hierarchy here. I mean, clearly Kerala is getting closer to the correct numbers somehow. Delhi's not that far off. Maharashtra and Tamil Nadu somewhere in the middle, and then the Bihars and the UPs are sort of off the charts.
And, the qualitative assessment here, and everyone's going to have their own sort of, these are complex interpretations, et cetera, and we're trying to summarize a year of tracking cases, et cetera. But very roughly, Bihar, there was no organized response in the beginning because there was no infrastructure, right, in rural areas. There were some efforts at the panchayat level to accommodate the returned migrants. But in terms of the data, it's a real black box, as we've already heard. And it's really difficult to have a sense of what actually has transpired, although clearly we suspect that the death rates were much, much higher than what's reported. Delhi, in both waves, it was bad. It was the epicenter, of course, of the migrant and worker and oxygen crisis. Wave one was absorbed to some degree. The system wasn't completely overwhelmed, but as we know, in wave two, obviously the system was overwhelmed. And at the end of the day, whether you're Sweden or Switzerland, whether you're Bihar or Kerala, all the public responses have been problematic and difficult. And any place that was exposed that isn't an island nation like Taiwan or Australia is going to have a certain level of mortality. But the issue is always whether or not the system is overwhelmed. If there is a system to begin with, there isn't in Bihar, there is in Kerala, and then whether or not it's overwhelmed. Kerala, very high infection rates in the second wave, but has largely been able to absorb it, hence a relatively low fatality rate. Maharashtra, and we're talking mostly about Mumbai in our work, but the first wave, not as bad as it could have been in some ways. I mean, when we first heard about the pandemic and you're thinking, areas like Dharavi and the slums, you really imagine just an absolute calamity. And somehow it doesn't seem to have been as bad as one would have imagined. And wave two, as dramatic and sharp as it was, to some degree in Maharashtra, especially in Mumbai, and I'll talk about it a little bit more, was absorbed. Tamil Nadu is an interesting case because Tamil Nadu has a strong public health care system. And yet in the first wave, it was overwhelmed. There was little coordination. Second wave improved. And we think part of that has to do with the change in government at the time. And the DMK was much more proactive. This, as it turns out, so capacity. Obviously, we all understand that the ability to address the pandemic, including the welfare consequences, is a function of capacity. Capacity is a very sticky variable. It takes time to build state capacity. And again, just to highlight the extraordinary variance, and I mean, this is a very simple metric, problematic in certain ways, but to go from the Bihar figure all the way to the Tamil Nadu and Kerala figures, it's a factor of 4 in terms of the actual presence of the state. And then same with the health infrastructure. Whatever metric you take, Kerala is well ahead, and even Kerala as a state of 35 million that's spread across urban and rural, has way more nurses per capita than the capital city of Delhi, right? And expenditures, it's all reflected there. Now, capacity is important, but capacity has to be mobilized. You can have a lot of capacity, but without the right political interventions, that capacity is not going to serve the purpose of addressing a pandemic, especially when it comes hard and fast as it did in the second wave. So here I'm going to go quickly into the political science literature. There's been a lot of work in India by people like John Harris, Atul Kohli, Prerna Singh, who's here, on categorizing these subnational regimes. And the idea of a political regime is it's a political party configuration that's more or less stable over time, that reflects some underlying distribution of caste or class power. At least that's how John Harris first defined it. And I would argue, and as Prerna Singh has shown, political regimes in terms are highly correlated with building state capacity over time, increased social expenditures, et cetera. And so we use Harris's basic classifications and then we update them. And if anyone wants to challenge these, I'd love to hear the challenges. But the one I think we will agree on, or at least Prerna and I will agree on, is that Kerala is roughly what we would call a social democratic regime led by a programmatic party. For the first time ever, the LDF has actually been re-elected. Bihar is this kind of competing, alternating, broad-based, cross-caste coalitions, but they're both indulging in a kind of patronage regime. So whoever's in power is doing the kind of plundering that has been described by Kanchan Chandra and others. Delhi is a super interesting case because the AAP is a good governance party. It's India's only second urban-based party after the Shiv Sena. And it really did come to power on an agenda of good governance. And in the health and education sectors, they've actually been quite successful, increased water services across Delhi, et cetera, and yet clearly did not do a very good job either in the first or second wave. But in part because they're at loggerheads, right? The chief minister is at loggerheads with the government of India. They have limited autonomy of local decision making. They don't control the police. They don't control a lot of the key agencies. And so we believe in large part that explains, despite the fact of having high capacity, Delhi did a relatively poor job of coordinating the response. And then we have Maharashtra, which again, there's a huge difference between Mumbai and the state. The state's a coalition government, but it's pretty inclusive. And it more or less gave the Shiv Sena a certain degree of autonomy at the level of the city of Mumbai to address the problems directly. And we believe that's part of why the response in Mumbai has been more successful. So it is a fragmented coalition, but there's some multi-class, multi-caste accommodation happening there. And then finally, we know everything we need to know about Tamil Nadu because we have Kalai Arasan, who along with Vijay Bhaskar wrote the book on the Dravidian version of left populism, and Tamil Nadu has built out basic capabilities and underwritten social rights now for the better past part of a half century, and yet did not perform as well as we would have anticipated. So I'm not going to go through all this. There's way, this is us disaggregating and trying to, put some measure of coherence into what are clearly very complex political responses. But I want to emphasize 3 columns. The first one, so we would argue that an effective response requires some executive coordination, right? One of the great dilemmas of governance in India is the power of line department bureaucracies, right? They are vertically integrated organizations that largely answer to their own vertically integrated interests, right? And coordinating it, this is why there's no planning in Indian cities. The planners are powerless against the organized, vertically integrated bureaucracy. To have a coherent response to a pandemic, you need everyone on board, right? You need the police, you need the health officials, you need local school teachers who can be your frontline workers, etc. Someone's got to coordinate all this, issue the orders, make sure they work together. So this is what we call the executive function. And there's variance here. Tamil Nadu, wave 1, it was very poor. AIDMK, for whatever reasons, just was not coordinating on this. The DMK came in and very actively, very quickly started appointing municipal commissioners and coordinating across departments. Delhi, as I've already suggested, was divided between the chief minister and the government of India. Kerala, of course, the sort of prototypical programmatic party, the CPM, cadre-based, hierarchical, very sort of clear positions on everything. And from the get-go, they assembled all the departments and put the Department of Health in charge. This is key, right? And then mobilized the police, et cetera. Mumbai. So I want to tell the Mumbai story. Sangeeta Banerjee has been doing work on the Shiv Sena, and she confirms that this is true. Right? I mean, the Shiv Sena, whatever you think of it politically, exclusionary, anti-Muslim, etc., it is embedded. The Shiv Sena is in the slums. They have ties to the associations, the local workers, et cetera, and they were able to mobilize them, working with a strong municipal commissioner, right? Something that Delhi doesn't have. And then the JDU did provide some welfare support to stranded migrants, but no health response, in part because they had no system, they had no infrastructure to actually mobilize as part of the response. Third column, local government, and we don't talk enough about this. The single greatest weakness of Indian governance and Indian democracy is the weakness of local government. It is probably the most centralized democracy in the world. Municipalities have limited autonomy. Panchayats have been strengthened in the last 20, 30 years, but by any global metric, any comparative standard, local government remains very weak. Tamil Nadu, they haven't elected councillors in 5 years. People don't have councillors. People face the bureaucracy. They don't face a democracy, they face a bureaucracy. So there's very little coordination at the local level. Delhi, centralized command center was set up, but there were no ward structures to work with. And again, that's a legacy of the divided sovereignties of Delhi. Kerala, again, those of you know Kerala's recent history, about 30 years ago, they devolved about 40% of all developmental planning resources and functions to the panchayat level. Panchayats in Kerala have these beautiful primary healthcare units with doctors, with machines and stuff, and they're nice and they're clean. There's real presence of health infrastructure at the local level and the capacity to coordinate across the different departments, right? The police, the health interventions, Kudumbashri, the various civil society organizations. And that's really where I think the relative success of Kerala to absorb, the sheer magnitude of the pandemic in the second wave really comes into place. And then in Mumbai, the wards are very powerful. They had their war rooms all coordinated through the BMC and the work of the municipal commissioner. But the point is there was a political infrastructure there at the ward level to work with. And then finally in Bihar, the panchayats, as Ani always reminds me, are politically very powerful and politically very significant. But they weren't really leveraged and they didn't have a lot of resources to work with in the first place. And then the final column is civil society, and this is the hardest thing to measure. We all know this may be the most important thing, but we in sociology like to say that states can't do anything, they can only co-produce things. Co-production means working with teachers, health workers, Anganwadi workers. It means working with the elements of civil society. These are difficult relationships to develop, and obviously they're much more developed in some contexts than others. So I don't want to go over time. Very briefly, so what went wrong? I think politics, as we heard from Barkadat, she talks about the missing state. We were debating this. The state isn't missing, it's clearly there, but it is indifferent, or it was indifferent at certain moments, for certain. But there is a pattern, and again, the data folks know this much better than I do, but it does strike me that the states that seem to have the most underreporting are BJP states, UP, Gujarat, Madhya Pradesh. And the other states tend to do a little bit better. So there's some opacity in the data, there's some paucity in the data, and maybe there's some political suppression of data as well that's going on. Political party animosity, not competition. Competition is part of the democratic system. But there are political configurations where the parties are severe loggerheads, hence the term animosity, which is the best we can come up with. AIDMK versus DMK, BJP versus Aam Aadmi. These are existential conflicts, right? Kerala politics, Congress, CPM Congress, they fight and all that, but it's not existential anymore. It's a quasi-pact, and they alternate in power. Lack of executive action, especially in wave one. And we think part of that had to do with the fact that everything was coming from the center. The big lockdown, the data, the basic directives, and initially state governments were a little slow to respond with their own initiatives. Second wave, they did better, because at that point they developed more systems, et cetera. So overall, the bureaucracy or the public health infrastructure, we know this, it's weak. But I think one of the political problems is that even where public health infrastructure was available, they weren't always given the lead role, and Tamil Nadu's case in point, in actually addressing the pandemic. And then local government in general, undercapacitated, underutilized, overwhelmed. And here, the distinction between Delhi and the BMC is really clear, right? The BMC has capacity, it's a much more autonomous municipal corporation. It has systems in place, it has its own bureaucracy, including some very committed frontline officials. Whereas Delhi is the most divided jurisdiction in the nation by far. Right? And then Kerala versus Tamil Nadu, they both have equally good public health care systems. They both have the reputation for having very strong IAS officer cadres and relatively solid bureaucracies. The difference is Kerala is truly decentralized and Tamil Nadu is not. And to end on a somewhat more positive note, there were some things that went right, especially over time. Politics, parties that are, quote, embedded. There's all literature on this, I'm not giving you things. So, but the CPM, the Dravidian Party, or at least the DMK, and the Shiv Sena, as different as they might be ideologically, they're different from the Congress and other parties to the degree to which they're actually embedded in local civil society structures, et cetera, and allowed them to have more effective response. I think there was, despite the fact that the second wave may have cost more lives, it also came on much faster and harder and people weren't as prepared. There was a lot of learning between wave one and wave two. And we see that especially in some of the policies in Mumbai. We often forget in these discussions about weak state capacity that it's very uneven and that there are a lot of very dedicated agencies and frontline bureaucracies across India. Barka Dutt and other journalists have reported on district commissioners and magistrates who are very proactive and mobilize local resources. And I think we need to learn more about what characterizes those kinds of effective frontline interventions as opposed to the more common image of a bureaucracy that always fails. Ani points out that in Delhi, school teachers were mobilized to do food redistribution during the worst of the lockdown. The frontline bureaucracy, in other words, was repurposed. In some places, the police was brutal and even violent. In other places, it was part of contact tracing, as in the early stages in Kerala. Anganwadi and ASHA workers have been sometimes heroic, going into the slums door to door, identifying people who need help or access to welfare or food. And then Ani also points out that even in weak capacity states, sometimes it was possible to mobilize the disaster management authority to at least make some welfare interventions, if not always health intervention. And then a final point is we need to think more about the ways that the state can be in society, can be embedded in society. We see this in Dharavi, the door-to-door capacity of the state to work with street level committees and go and help families, individuals, et cetera, is stunning. Likewise, in Kerala, the panchayats in association with this women's movement called Kudumbashu was really key to the response. And it's hard to sort of figure out exactly how this works, but we know it makes a difference. Thank you.
I'm gonna ask if all of you guys would just come up. Mostly because, I mean, from a video point of view, it's easier to see. And we've gotten some questions, or we're gonna get some questions from our online audience that Point3 is gonna text me. So if you watch me looking at my text messages, I'm not trying to sell stocks or anything. I'm just trying to get the questions. Well, thank you for three fabulous, very complimentary and really comprehensive set of conversations and papers and discussions. And there's so many that I have, and there's some specific questions I have and some big picture questions I have. And maybe I'll start off with a big picture question and I'll let any of you answer, though I suspect I think of a couple of you who will. Which is the issue around improving the accuracy and reliability of available data and making it more readily accessible, kind of real time. So we're not waiting till 2024. And so the question is a two-part question really related. One is, what are things that policymakers can do in the short run to start making better data available more quickly? And is there a role for data from the private sector? And let me explain a bit what I mean by that. When I think about the pandemic in the US and what I track almost every day, beyond the stuff I look at from the CDC, et cetera, I look at data from open table reservations because it's a really good measure of how people are thinking and feeling. So you could see the wave in Florida going through July and know that we were nowhere near done because restaurant reservations were above their 2019 average. And so you could see people were not pulling back activity. Google Trends and Google mobility data is another source of really good data. So there are all sorts of interesting data sources that are cropping up that aren't from traditional government, public health. How do we begin to use some of those to complement? So what can we do on the public side? And then how do we think about bringing in data from the private side? And Professor Mukherjee, maybe I'll ask you to start us off, but then after that, Professor Subramaniam and Professor Keller, if you want to add anything to that as well. But Brahmar, to you first.
Yeah, thank you for that question. And I think this is a great opportunity that so the government at one point of time talked about this digital national health ID. And I think that would have helped if there is one thing which puzzles me is that we have this database. One is this COVID vaccination database. And then every test is reported RT-PCR database. And we also have the genomic sequencing database. But there is not a real-time nimble linkage so that I can see that this is the trajectory of a person got vaccinated, got an RT-PCR test, and in between two vaccines, they got a COVID positive infection. So we need to really link them. And I think that some kind of common linkage ID will be really helpful. And crowdsourced data, for example, all our models are based on data from this platform, which is really a nonprofit volunteer-driven platform, COVID-19india.org, and they are like ending their operations as of October 30th. So all our models are going to stop because there is not a good, reliable data source where we can get daily time series data. So web scraping and all of these tools, it's doable, but you need to invest, and the cost is not that much.
Right.
So I think that this is multi-platform linkage is really a key. And so I think the emphasis with all of this work, if we can come up with some recommendation and move the needle a little bit, that data is really important, is at the heart of policymaking, at the heart of data-driven decision making. That's really important. For example, as you mentioned, Google Trends, Google Flu, but you will probably miss a lot of the rural data if you try to rely on those data sources. But inactive Aadhaar cards, rations that that have not been picked up in the cities, medical claims, all of these things, if there is a nimble way data tracking, I think that would be a really good use.
Great.
So
Arvind, any thoughts on?
Yes, so Ashish, see, I don't know the health sector very well, and I defer to experts on this. So there's clearly a kind of capacity issue, which Patrick very eloquently spoke about. I think this government also deserves a lot of credit for seeing the power of and harnessing technology for actual delivery, but also for data. And I think for all its limitations and things, I think they've done a good job, and I think obviously they need to do more. But so this capacity, this technology, but then there's also incentive and politics in this. And it's no secret that this is not the only sphere in which government data have been deficient. As you know, in the last 2 or 3 years, lots of questions have been raised by other economic data, whether it's GDP, whether it's employment, whether it's poverty. For example, India does not have an official poverty estimate since 2011 because the 2017 numbers that were done were pulled back. And now COVID. So across the board, I think data integrity has come under question, and therefore I think for all that we say about we need to invest more in capacity and technology, and those are all absolutely essential. I think, but fundamentally, if the state and the government are not on board and believe in open, honest data, it's going to be a problem. So I think, and I think that is the binding constraint on. But then it leads to your second part of your question. Therefore, absolutely, you need to, supplement that with, and I only know about the economic sphere, that we do, given that official data are have their limitations. I think more and more people have come to believe that you need to track this official data, whether it's Google Mobility or all kinds of things that we can do. But then finally, that complementary effort will be good in terms of raising data awareness and things. But when it comes to state action, that may not be enough to kind of really push state action. So I think in some ways we need a much more a cooperative state and a state that believes in openness and open data and honest, transparent data. I think there's no kind of that ends up being the binding constraint in many of these areas.
Patrick, I'm going to ask you to run your political science hat, and think about, why is it that in every country in the world, almost every country, I mean, in the US, we don't have high quality data for this pandemic, which is insane. and CDC is not tracking like critical things that we need. It is not a problem of money. It is not a problem of technical capability. It just somehow every single political and bureaucratic leader says it's really important and they're going to invest in it. And somehow magically every year it never quite gets done. I think Arvind sort of alluded to some of what's going on. How do you see that phenomena playing out? And how do you, how do we understand it? And then what do we do about it?
Yeah, and to pick up what Arvind said, I mean, look, data is knowledge and knowledge is power. And states and political actors are in the business of, they are, complex organizations dedicated to the principle of getting into power and staying in power. And so I know this is going to sound facile, but we have to democratize data. GIS, for example, geographic information systems, incredibly important in responding to a welfare crisis such as Delhi had during the lockdown. The state of Delhi, when they realized that they had to get food to people, did not know where their PDS shops were, because that GIS data was in another department that wouldn't share the data. And this is just departments hoarding data, et cetera. GIS data, by and large, is not the data that's available in different agencies is not available to the public. So that's one obvious example. And the other obvious example is to go back to something Barka Dutt said this morning. When we collect data, we collect it oftentimes in ways that render certain people invisible. And the one obvious example in the Indian context are informal settlements. I've been doing survey work with Ashutosh Varshney, hi Ashu, and a bunch of people. And one thing that we've noticed time and time again is that all the official data collection techniques systematically miss informal settlements. And these are the most vulnerable populations. And this is a political issue. The bureaucrats literally believe that these are temporary populations.
Right.
They're just peasants, they'll go home soon. And they've been there for 50 years.
Right.
Right?
3
And so that's
generations.
3 generations, and it's attitudinal, it's built into the bureaucratic ethos, et cetera.
Right, partly because they don't fit into the scheme that the bureaucracy has created. We see this with healthcare workers, where we basically undercount healthcare workers by 70% and say these people just don't exist, except that they provide 70% of healthcare. Yeah, Arvind, please.
Ashish, it's a great question. What can be done about it, right? And I keep going back in this to, Amartya Sen had this famous comparison between India and China, right? Where he said, look, China, great at doing things that require ongoing delivery of services, malnutrition, poverty, etc., but very bad at the Great Leap Forward and avoiding catastrophe. He said India, on the other hand, because of its democracy, because of decentralization, because of openness, the ability to respond to extreme events much better in an open democratic setup. So in some ways, if you believe that there has been a shortcoming here, it speaks to the kind of in some sense to kind of the democratic process itself. So unless the democratic process rewards and punishes in this instance of really extreme catastrophe, then I'm not sure, how much we can be confident or, how we can gain any measure of confidence. So in some senses, the buck has to be the democratic system, democratic process, unless people hold those in power accountable for these outcomes. And in some ways, we're going to see, to some extent, you could, Ashish, you know this better. To some extent, the US populace did hold,
No doubt.
So to that extent, and we saw a change. So something like that, I guess, has to happen in India as well. And unless we have the deep accountability, I think I would be a little bit, not very confident.
Sounds like I asked a question that my panelists don't have any thoughts on.
I just want to add one thing. There is also a question of the politics and the populist regime, and everything is tied together. For example, the app Arogya Setu, right? So that was designed with a very good intent that it will talk to the testing database, and every time you see a positive test, then in the neighborhood and all the contacts are going to get alerted that there is a positive exposure there. But nobody, actually, it is not feasible. So it's also the will and intent and commitment and culture and trust
Yep.
that has to be integrated with the data framework.
Yeah, that's a great point. Fair enough.
I just wanted to follow up. Thank you for this great panel on this, I think, quite interesting exchange between Patrick and Arvind about, the democratization of data and what that reflects about the state of democracy more broadly. So I wrote a Washington Post op-ed about this a few weeks ago, but to me, it's not at all surprising and deeply linked that in March 2020, Freedom House, as well as a bunch of other global watchdogs of democracy, demoted India from being a democracy to being an electoral autocracy. And Freedom House was actually more generous. The VDEM Institute, which is in Gothenburg in Sweden, actually went even a notch further. And so if we go back to that classic Dresden-Sen argument, the key thing about why they think India has done better at natural disasters, at famine, and I think this is Arvind's point, the mechanism of accountability in a democracy are twofold in that argument. The first is a free and thriving press, and the second is a robust political opposition. And they term these kind of emergency signals. They say that, a famine is not caused by a shortage of food. It is instead caused by a lack of information and communication and accountability. And it's these two mechanisms that hold democratic governments accountable. So to me, and then if you go back and read on what are the criteria on the basis of which India has been demoted, the lack of a free press is absolutely critical. So I think somewhere in this, and this gets to the point about data, web scraping, what are we scraping, where is this information coming from, is the kind of pulverization of civil society, of a free press, and the complete collapse of an opposition are, I think, key factors that both explain the suffering and also explain why we don't have data on the suffering. So it's less of a question and more of an observation.
No, those are great points. And I think about, you brought up the United States. I mean, two quick things that I would say. First of all, there is zero doubt that Donald Trump lost because of his mishandling of COVID. Right. If he had managed it a little bit better, he would have been reelected, which is an interesting point unto itself. But the second is there was, to Prerna's point, there was a thriving press and there was a very strong opposition that was able to capitalize on those missteps. And so without that, it would have been a much, much harder situation. So you really need all of those components. That's a great, thank you for that. Anything else? I saw more hands up there. Yes.
So I had a question for any of you, but really, Professor Mukherjee, I think what India's two waves also show us is what happens, the nature of public intervention. So with the first wave, there's a centralized, national, very tightly controlled by the Ministry of Home Affairs public intervention. And then we see all the variation that Patrick presented in our paper on what the subnational response looks like. And I was just curious to know, again, I haven't looked at the data the way you have, of course, is that you talked about, modeling these different kinds of intervention. And really now we have the ability to look at these two kinds of responses. And if you had thoughts on where would we have done better and where have we done better? Because I think the verdict is still out. I don't think we can say that the subnational very, very varied responses were necessarily better given how hard the second wave hit. So just, preliminary thoughts, if any, on these two.
No, that's a great question. And actually, that's the topic of the paper. We are revising 71 pages of response to reviewers. But because you cannot really, because when you are doing this counterfactuals, right, because we do not know. So what we did was essentially take the national lockdown intervention effect. And of course, we have all the data. We can see what happened after each of the unlock phases as well. So we can apply that, saying if that had happened in March, what would be the case counts, right? So obviously they will be drastically lower. The problem is that I think that it's, you heard from this morning that the smart lockdowns are probably a very potent public health intervention if implemented correctly with restriction of mobility. So the thing is, India, things move, right? So it is not Maharashtra or Kerala where this outbreak is going to be contained. So you have to be smart and agile and really be nimble with respect to these data guided metrics. So if you compare that, and if you look at India's moderate type of lockdowns, I think it could work if the timing was right. It's not the strength or the measures of the lockdown. I think timing is key. By April 14th, when Maharashtra actually went into a full lockdown, West Bengal was waiting for the elections to be over. It's too late. The same measures, even weaker measures earlier, which does not disrupt human lives, public lives like that, would have been a preferred choice. That's why I think it's also a policy conundrum, because if you do it too early, people will not believe you because it did not happen, right? So it's like, what is the counterfactual? We did not need it. But if you wait, you cannot prevent it. So that's why these types of retrospective analysis becomes very important to give to policymakers. If you had acted when you saw this R, this test positivity rate, this number of cluster infections, so you know that new variant is emerging, then if you really intervened, 15 days would have been with the same measures or even weaker measures could really save lives. I think this is very important to understand and articulate and quantify.
The one part of the problem, as you know, is that people don't understand exponential growth. And so they don't understand that once you're into exponential growth, it's all about time. And even, I mean, this is data from New York, that if New York had locked down a week earlier in March of 2020, it would have saved 50,000 lives. And people think, how could that possibly be? But once you're in that very steep part of the exponential growth, every day is just awful. And that's basically what happened. And for most people who don't know, I mean, Professor Mukherjee was, I think you started really in later part of February saying we have a problem. And I was on TV probably in early to mid-March in India, so 2 weeks behind you, which is where I felt like the whole pandemic. I've been about 2 weeks behind Brahma. But I was saying like we have a problem. And it was a month. And a month is a lifetime in an exponentially growing disease. Let's say, did you have a comment on that? Yeah.
I have a, you know, I don't want to, you see, I think, Ashish, you know, I think we need a little bit of, both in our political analysis and things, I think we need a little bit of humility here, even as scientists, because the truth is, you know, science has played out in real time and on, you know, data screens, and you know, the science has been messy. The science officials, you know, the scientific community has also not always covered itself in glory in this. So the whole process of public reason that Amartya Sen talks about, you know, science and everything, I think it's been, COVID has really upended many of our assumptions about, you know, scientists good, you know, believe them, trust them. And so I think, therefore, when we fault, you know, society for, you know, not understanding this or not doing this, I think it's a bit more, you know, it's a bit more. So, for example, you know, to Prerna's point about even India and, you know, democracy, decentralization, accountability, and so on. I mean, you know, people say, oh, you know, they did their best. They couldn't have done more. You know, did they do any worse than somewhere else? And so the whole, you know, what goes into people's information set and how they process that, I think, you know, we're at the very, very early stages of understanding that. And I think, you know, we're going to have to refine our views on lots of things, even because of what COVID has done and what has happened.
Well, I'm getting the signal from several folks that we have to take a break. This was an extraordinarily fabulous panel, both in the discussion, but really in the presentations. So big round of applause for our panelists.